Now we are moving on towards the treatment of spondyloarthropathies. How to treat these problems. Now we'll be discussing how to manage when a patient comes to you with ankylosing spondyloarthropathy, especially what to dig on history, then on examination, and what are the general treatment guidelines. For example, when to start physiotherapy, when to start the medical therapy, and eventually the surgical options we have for ankylosing spondylitis. Coming to the history. Patient's most common symptom would be the low back pain, stiffness, which is usually early on. Later on, once the patient gets used to this kind of stiffness, they kind of modulate their activity in such a way that stiffness is not the main complaint. But if you dig out the history in detail, you usually realize that they do not pick up things when they fall down. They ask somebody else to pick it up. Why? When you ask them in detail, so usually the reason is that we cannot bend our back forward, especially flexions actually get problematic. Then they can usually they have, if the patient is active mover, they usually tend to limit their activities as well, and this is actually to compensate for the back pain they get when they are moving around. There is increased stiffness and decreased range of motion at spine. This is a kind of gradual process that happens, that as the stiffness increases, the range of motion decreases and their activity of daily life actually gets limited by this problem. Extension affected early, and it actually the most affected part. Extension is they can go back, especially for example, the people when they're lifting anything, it's very difficult for them to lift anything up, or when it falls down is to bend forward and lift it up. That becomes very problematic. Now coming to the examination, when you have this kind of history, you are thinking on multiple lines what to rule out on examination and what to look for in spine and hip and pelvis. And the most common thing to do is the wall test. As I've already dictated and told you in previous sections, that wall test is actually a test is the patient is simply asked to stand with his straight back and with his occiput touching the wall as well as his heels touching the wall. In a normal person who is flexible enough and can extend his or her back, that will be very easy. When the patient will be standing straight, the occiput of the head would be touching the wall, the back of the shoulder, the scapula would be touching the wall, and then it would be the area of the buttocks, and then the heels would be touching the wall in a normal person. But as in case of ankylosing spondylitis, their neck is actually bent forward like this, so it's very difficult for them to actually extend their neck so that their occiput can touch the back. Similarly, shoulders are actually dropping forward, so they cannot push their shoulders back. Extension at the spine is actually difficult, and it is actually severely affected. As a result, to actually extend their back so that their shoulders touch the wall, that becomes increasingly difficult and very painful, so they don't really try to do it. So that is actually a kind of a simple test that you do not need any fancy equipment, that you can realize that there is something wrong with the alignment of the spine. Now coming then, once you know that the problem is somewhere around in the lower back and the pelvic area, then probably the next better thing would be to go for an X-ray, that is plain film straight away, AP and lateral. In case of spine, there are lumbosacral X-rays, AP and lateral views. Then you can get X-ray pelvis, AP view with both hips as well. And if you're suspecting, as this is not a isolated bony problem, it's a systemic disease and there are associated soft tissue abnormalities as well, then MRI can be very helpful in delineating this, what is the soft tissue pathology associated with ankylosing spondylitis. Then once we are planning for, we have made the diagnosis or we are on making the differentials at this time, then we can get the labs as well, which will show a different picture. Probably ESR would still be raised. This could be due to any other reason, and there's some kind of an inflammatory process is there going on. Therefore, ESR and CRP usually are raised. Then comes making the differential. What are we thinking on these? What else we would be thinking other than ankylosing spondylitis? Usually, it's very simple. Low back pain. The differentials include simple. It could be as simple as myofascial pain or back strain. It could be ankylosing spondylitis. It could be some kind of osteoarthritis of the hip. which may be having, or it could be simply spondyloarthropathies like spondylosis of the spine as well, in which there is a slippage of vertebra. Now the back pain could be due to any reason, but usually once you get the x-rays, this very clear cutly shows that it is most likely ankylosing spondylitis. Then if you made the diagnosis, if it's ankylosing spondylitis, what would be the treatment? That would include general measures to maintain satisfactory posture and preserve movement, which includes anti-inflammatory drugs to counteract pain and stiffness. Now, use of NSAID is actually not kind of a disease modifying. It does not really stop the disease process which is going on, but it helps in a way that it actually relieves patients of pain. Once the patient is pain free, he or she can mobilize and get exercise and physical therapy can be initiated. Therefore, actually the stiffness of the joints which decreases by physiotherapy. Therefore, in a way, it's helpful that it makes patient asymptomatic. A patient is able to do his or her physical therapy continuously and actually can participate in different range of motion exercises, so that which is going to be then further enhance or slow down the process which is occurring in his or her back. Then coming to the drugs, which especially are actually tumor necrosis factor inhibitors, that has been shown because they are usually these kind of HLA-B27 involved. There is some degree of genetic component as well, and then there is cascades of these factors which are involved during the pathogenesis of the disease. Therefore, use of TNF inhibitors has helped to reduce the severity of disease. But if, for example, we are unable to do anything with if the disease is not controlled with NSAID and the use of TNF inhibitors, or the end state damage has already been done. For example, there is already high degree of ankylosis at the sacroiliac junction. So then something has to be done for the sacroiliac junction. Otherwise, patients with complete ankylosis would not be able to flex or extend his or her back. For example, there is end stage ankylosis at the hip joint that you cannot reverse that ankylosis by simply giving medicine. You have to go for some kind of a surgery so that the patient becomes pain free. And the point is, probably by the time the end stage ankylosis has occurred, patient is already pain free. Now the problem is not the pain which was initially there. Now the problem is movement. Patient is unable to flex, extend, or lateral flex his or her spine. That is where the real issue is. The issue is with the daily activities of daily living, which cannot be carried out with ankylosed joints. So what are the general measures? Patients should remain active and follow their normal pursuits. That is the first and foremost thing. You cannot pay these patients sit down with ankylosing spondylitis. If these patients are going to sit down, that is going to further aggravate the problem, because their joints are already not moving properly, and if they're going to not move, then eventually contractures are going to develop, and which is going to further hamper problems for these patients, so they won't be able to carry out their activities of daily living. Then it's maintain satisfactory posture, perform spinal extension exercises every day. As you can see it in this diagram, that these are some of the exercises, extension exercises. Now there are different exercise regimens, different physiotherapies recommend, but generally it involves all kinds of range of movement, that is flexion, extension, and lateral flexion of the spine. Then swimming, dancing, and gymnastics should be encouraged. If the patient was already doing something or was used to doing something, this should be encouraged, because making the patient pain-free, once the patient is pain-free, these activities would actually rather help the patient get rid of the disease. Then is the rest and immobilization are contraindicated because they increase the general feeling of stiffness. Coming to the use of NSAIDs, as I've just told you, the non-steroidal anti-inflammatory drugs control pain and counteract soft tissue stiffness, but making it possible to benefit from exercise and activity. The problem with them is they are doubtful whether these drugs prevent or retard the prognosis of ankylosis. So the point is that you have to decide whether this patient is at what stage of disease. Is it at those early stage that yes, you can give them NSAIDs, you can make them pain-free and ask them to exercise and carry out their daily activities so that they would be okay with the simply painkillers. Are they at a stage where they need something more than painkillers, that is TNF inhibitors, or at the stage of the disease is such end stage that they probably would benefit best from having a surgery rather than medical therapy? Now coming, medical therapy means use of TNF inhibitors. Actually, there is a TNF receptors on our cell membranes, and TNF alpha and TNF beta, the two main things, tumor necrosis factor alpha and tumor necrosis factor beta. These inhibitors actually block this TNF receptors. As a result, the cascade which is initiated by these receptors is actually blocked, resulting in decreased inflammatory response to the disease. With the introduction of TNF inhibitors, it has become possible to treat the underlying inflammatory process, which is active, results in significant improvement in disease activity, including remission. That is, that disease can be controlled to a level that it becomes almost negligible, although it cannot be completely eradicated. But yes, patient is as if it is disease free. Now, if the patient presents you with end-stage disease, for example, it's bilaterally enclosed hip is there. Now, the problem would be the patient won't be complaining of pain. The patient will be complaining that being enclosures of the hip results in decreased movements. As I think the patient will not be able to sit in the chair, will not be able to get up from the chair, and similarly, carrying out daily activities would be impossible, especially squatting in the bathroom. That would be very difficult for that of the patient. So these kind of problems, when they arise, this results in some kind of a surgical treatment. And this is in the lower section, you can appreciate over here that bilateral ankylosis of the hip in the stay or late onset of ankylosing spondylitis has been treated with bilateral total hip arthroplasty. Eventually, both the joint have to be replaced so that the movement can be restored. On the right side, you can appreciate that there is actually lumbosacral ankylosing spondylitis. This lordosis of this has been restored by fusion, which has actually, as the extension is lost, the posture becomes such that actually lumbar spine gets more kyphotic. As a result, this is this hyperkyphosis. This is actually to be treated by posterior fusion. Now there are also multiple options. For example, in spine, yes, we have option of orthodesis in terms of replacement, but replacements is always better because it actually restores movement. In spine, we have also option of osteotomy versus fusion. Sometimes fusion is better because it actually, although it does compromises movement, but it actually provides stability, because a spinal cord is actually passing through the vertebral column. So we cannot risk laceration, a complete cutting of spinal cord at the cost of movement. But sometimes it depends what kind of situation it is and whether this patient would be fit for osteotomy, that is cutting a wedge out of the spine so that that can be straightened, or it would require a fusion, that is putting the screws at the back of the spine and fixing it in a certain position. Now this is a diagram which is showing an osteotomy. As you can appreciate, this is the the lumbar spine have actually first straightened and is actually becoming increasingly kyphotic. To restore the lordosis, this is the kind of a wedge osteotomy they have done, resulting in restoration of the lordosis. Which this type of osteotomy is called as pedicle subtraction osteotomy, and then it has to be fixed with screws because otherwise this will not be stable enough. Coming to the complications, now the complication includes spinal fractures. Spine is often both rigid, and osteoporotic fractures may be caused by comparatively mild injuries. The reason is the patient has having a rigid spine, then it is more prone to spinal fractures. Most common is through C5 and C7, which is highly dangerous because it is where the brachial plexus is, and mostly, which means upper motor region, a kind of a problematic problem where you have a whole quadriplegia which can occur in the patient. Treatment in these cases is directed at preventing further deformity. The other is hyperkyphosis, especially patient has difficulty lifting his head to see in front of the feet because the actually cervical spine is also going into the kyphosis, and once the kyphosis is too much, the patient head falls down and patient unable to look upward. As a result, to look up, they had to look like this. and they are most of the time acting and seeing like it this, other than straightening up their neck so that they can look forward. Spinal cord compression, this is also possibility caused by atlantoaxial subluxation or ossification of the posterior longitudinal ligament. As there is already instability, sometimes instability leads to hypertrophy of the ligaments, which can further compress the spinal cord. And last is the lumbosacral nerve root compression. That can also, because usually the most common areas are the cervical spine and the lumbar spine, which are affected. Once the lumbar spine gets unclosed, this residual patients may develop including lower limb weakness, paresthesias, and in addition to their usual pelvic girdle symptoms. And if usually this bowel and bladder function is spared, because that is actually at the sacral level. Mainly it is the lower motor and lower femoral plexus which is actually affected most of the time. Thank you very much. Keep watching sqadia.com.